So what will I be covering in this talk? Now, bone marrow transplant is one of those really scary topics, and people have a lot of ideas about it, thoughts about it. They read about it online. So I kind of want to just give some basics on, first of all, what is a bone marrow transplant. I want to talk about who are donors, what is required of a patient who's going to undergo a bone marrow transplant, talk about the risks of it, when you need to start thinking about it, and what is the timing of transplant. And especially for the last two, I don't have a lot of great answers, but I can certainly at least shed some light on the way I think about it. So what is bone marrow transplant? Basically, bone marrow transplant involves either high or intermediate dose chemotherapy, followed by an infusion of hematopoietic stem cells. So what does that mean? That means that we're taking bone marrow stem cells. These are not any of the stem cells that are controversial. These are stem cells that make the blood system. What we do is we give chemotherapy to a patient, and I'll go over all of this with some pictures later on. That's designed to reduce the amount of disease burden as well as suppress the immune system, and we provide a new blood system. This new blood system is not going to be unhealthy like a blood system that has a myeloproliferative disease. And hopefully the new immune system that we give somebody can actually fight off the myelofibrosis, because as we've been learning over the last few hours, these blood systems that have a myeloproliferative disease involved with them are actually very strong. They don't want to die. That's why they cause so many problems. So hopefully this new immune system can fight off any bits of this last myeloproliferative disease cells that are hanging around. Now, historically, we used to only transplant patients. Initially, it was actually under 40 years old, then it was under 55, and then it was under 65, and now we're up to 75. And actually, there are some people who transplant up into the 80s, but I can't say I endorse that. When you hear about different types of transplant, a lot of times people will say, oh yeah, I know somebody who got a transplant for multiple myeloma, and man, they were better in like a few months. Well, there's two different types of transplant. There's autologous, which is where you get your own cells back, which is using the premise that you're going to be able to give high-dose chemotherapy for some type of malignancy. And then there's allogeneic, where you can actually use donor stem cells, and that's the type we'll be talking about today, and that's the type we use for myelofibrosis. So what are the alternative names? Everyone comes to me and say, okay, well, I've read about peripheral blood stem cell transplant, hematopoietic stem cell transplant, bone marrow transplant. What does this all mean? Basically, this is all the same thing. We are acquiring stem cells for the blood system that live in our bone marrow, and we're giving them to somebody else. When we talk about peripheral blood stem cells or bone marrow, it's how we collect them. Sometimes we can actually give medicines that make the cells that are, the stem cells that are living in the marrow come out to the peripheral blood. We can collect them from the peripheral blood, hence peripheral blood stem cell transplant. Another way of doing it is we can actually physically go in and pull cells out of the bone marrow, which requires a trip to the OR, and I'm sure most people in here who have an MPN have had a bone marrow biopsy. It's basically like having 50 of those biopsies on each side, at least. Now, the person's under general anesthesia, so, and actually, surprisingly, they recover pretty well from it, but that's the different ways we collect the stem cells, which is why you hear people say bone marrow transplant, stem cell transplant, hematopoietic stem cell transplant. So there's lots of different nomenclature for this. So when somebody refers you to come and see somebody like me, it's a few things that are important to know. Number one, don't come by yourself. Bring somebody with you. You need a second set of ears, because a lot of what you hear will shock you. Your brain will turn off for a couple minutes, and then when it comes on, you want to make sure somebody else is kind of hearing the same thing, because then you can also go home and compare notes. Be prepared to be scared. Part of my job is to make sure that I give a very clear and open impression of bone marrow transplant. Therefore, I do have to discuss the risks and some of the scary parts of it. It would be wrong of me to say, oh yeah, it's a piece of cake, you're going to be fine, everyone's fine after bone marrow transplant, because that's not the case. If you can, try to record the consultation. Where I trained as a fellow, they actually had little tape recorders in each room, so it was like a mandatory thing. And I think it is very, very helpful, and I actually appreciate it when somebody comes in and says, can I record this on my phone? Do make sure you tell the doctor you're doing it, because it's a little unnerving to find out that you've been recorded, but either way, it's a really important thing to know, to have something to go back and listen to, because you'll find that you'll be like, okay, yeah, I get it. And then you get in the car and you're like, what was she talking about? And so it's important to be able to go back and listen to it again. And if you have any doubts, get another opinion. I know I certainly, whenever I see anyone who seems to be a little bit on the fence about whether they want to do a bone marrow transplant or has concerns, I always tell them, go get another opinion, talk to somebody else about this. Don't just take my word on it. And it's very important that you feel comfortable with what you're going to do and don't just, blindly rely on what I tell you. So the sequence of events, so, once you come in, we say, okay, I think a bone marrow transplant's probably a good idea for you, and you decide to move forward. You identify a donor. You make sure your other organ systems and everything work adequately. You get admitted to the hospital. You get chemotherapy or radiation therapy. And again, I'm giving a very general overview. Things are very different depending on the specifics of your center, your doctor, et cetera. The stem cells go in. That is the infamous day 0. It's your second birthday. It actually is a pretty anticlimactic thing. It's like a blood transfusion, but it is a big deal because this is sort of the start of your new marrow, your kind of hopefully new lease on life. There's about a 3 to 4 week hospital stay after that. So you have a week of conditioning, you get the stem cells, and then you're in the hospital for at least another 2 to 3 weeks. And then you have to stay close to the transplant center until day 100. I've not found any transplant centers that don't have this rule. So who can be a donor? So first of all, in myelofibrosis, it's a little different than some other diseases. So for the purposes of patients with myelofibrosis getting a transplant, we first look at brother or sister. They have to have the same mom and same dad. Half brothers and half sisters, for the most part, won't work for myelofibrosis. Then we look at a matched unrelated donor. Ideally, we want a full match. And of note, a lot of people say, well, what about the blood type or something? Blood type doesn't need to be the same. Unfortunately, if you look like your brother, they're not going to tell you that they're going to be a match or sister. You don't actually acquire any of their traits. So if you think your sister's really annoying or your brother's really annoying, it doesn't mean you'll be annoying after your transplant. But now, in other disease types, so people who have acute leukemia, myelodysplastic syndrome, we actually have other methods of donors that we can use, such as using a mismatch, so a 9 out of 10 donor, or using a half-matched related donor. Those are still kind of experimental in myelofibrosis. We can do them. I think there's certainly ways of trying to do that, but it definitely requires a little extra discussion with your physician. So when people say, oh, well, geez, 10 out of 10, 8 out of 8, what are you talking about? And I always like to put this out. So these are all your genes right there. And on the sixth gene that you have, and this is only one set, you all have 2 sets. And so on one of those genes, it has HLA markers. Now, HLA is kind of what helps identify you as you. For each of these, all of the A, B, C, D, R, D, Q, D, P, there's probably 300 or 400 different options for each of those. So you have these 5 that we look at, because generally, so 12 out of 12, we barely ever look at. Generally, we look at 10 out of 10. Some places look at 8. If we're looking at 10, you have 5 from mom, 5 from dad. Chance of your full sibling being a match is about 25%. So when we look at unrelated donors, it's actually a miracle we find unrelated donors, because for each of these, A, B, C, D, R, D, Q, there's 300 or 400 different options for each of them. The fortunate thing is the frequency of certain ones is much higher than others. This is when we say 8 out of 8, we're skipping at the DQ, and if there's 6 out of 6, which we don't really often use anymore, that's what we're looking at. Just as sort of an overview of how, when you see these different numbers, why is one doctor saying an 8 out of 8, another one saying a 10 out of 10, and then if you look at a haplo, you may be looking at 3 out of 6, which is really actually ends up being a 5 out of 10. But either way, that's just kind of a brief way to look at that. So how does it work? Again, you have a donor. The donor stem cells are collected either by the peripheral blood stem cell collection or a bone marrow harvest. Sometimes they're frozen, although generally when it's a donor from somebody else, we can usually manage to try to do all the timing right so that they get fresh cells. Because again, these aren't things that are in a freezer somewhere. These are cells that you actually get collected right around the same time that the transplant is. So somebody's in the hospital getting chemotherapy while somebody's out in the periphery getting their stem cells collected. And then you may say, well, geez, that seems awfully risky. I mean, what if that person gets hit by a car or they get sick or something? Or what if for unrelated donors, the stem cells are actually collected wherever that donor lives. So they may be collected in Germany. Believe it or not, I've been doing this for about 10 years, and I've only had about 2 or 3 cases where the stem cells didn't show up on time. And in one of those cases, there was a huge snowstorm. They were coming from Germany to Arizona. They got caught in New Jersey, and they were frozen there. And the patient got the stem cells 7 days late. No problem. She's actually still alive and doing well. I had another instance where somebody got sick right before a transplant. This patient got the cells 2 weeks late. She still is doing fine. So it's a scary process, but in actuality, even worst case scenario, something happens, we can usually salvage the situation pretty well. And at the end of the day, no matter how you collect the stem cells, I don't know if this has, yeah, this is what it looks like. A little bit of a bag. It looks kind of like, it's actually less than you would expect to see in a blood transfusion. I mean, it's actually kind of anticlimactic. You just kind of infuse it, goes in sometimes over an hour, sometimes over a couple hours, depending on the volume of the cells, and then it's done. In Arizona, we actually have a really great, we have the chaplain come in and do a blessing of the cells, and the nurses all sign a birthday card. So we do make a big deal out of it, because it is a big deal. But the actual process of it is kind of anticlimactic. So the chemotherapy beforehand, what's the purpose of it? As I said before, it's to try to suppress the immune system and control the disease. Now, the only thing you really need to accomplish there is suppressing the immune system. Ideally, if you get more chemotherapy, you control the disease better, but you have to suppress that immune system. So in some cases, your doctor will recommend using very small amounts of chemotherapy, so you might not actually feel terribly sick from the chemo itself. In myelofibrosis, we very seldom use radiation, although sometimes it will be used. So if it is part of the regimen, again, you have to trust your doctor on this one, but generally speaking, sometimes we'll use low doses of radiation, which will actually help suppress the immune system. When we look at intensity of conditioning, there's several ways of looking at it. I mean, there's several different intensities. First is myeloablative. And the way to think of myeloablative is no immune reconstitution without stem cells. This is something I very infrequently use in patients with myelofibrosis because I don't particularly need that degree of conditioning. Now, if I have a young patient, if I have somebody with particularly bad disease, high percentage of blasts, some of that goes into my decision making, and in some patients I will use an ablative conditioning, but I would say the vast majority I don't. Non-ablative is where it's just a whiff of chemotherapy and maybe a touch of radiation. And basically all you're doing is suppressing the immune cells. You're providing nothing really in there for disease control. I also don't very frequently use that because I think the risk of rejection is higher. But in certain situations, it's very appropriate to do. Reduced intensity is sort of somewhere in the middle. You're still getting some chemotherapy in there to control the disease, but not so much that you have a lot of toxicity associated with it. And generally, I like to use reduced intensity conditioning regimens. So what are the risks of transplant? Now, this is where everyone really gets scared. Graft versus host disease. I mean, I can't tell you how many people come in, they say, oh my God, I'm really scared of graft versus host disease. So I want to give kind of an example. And also, given that it's like before lunch and everyone's probably getting tired, this is a good time to do it. I want everyone in the room to stand up. All right. So you guys are all transplant recipients. All right, I want that half of the room to sit back down. Those left standing are the ones who will get some form of graft versus host disease. So half the people, approximately, will get some form of graft versus host disease. Now I want everyone to sit down except for the front 2 rows. This is a number of people who will get graft versus host disease that will make you pretty sick. It's where you have to use multiple therapies, you'll be in the hospital for a while. And that's a graft versus host disease that we sometimes see will eventually cause mortality based on a variety of complications. So if you look at all the people we start with, and then the number of people who have severe disease, the chances aren't as bad as you think. And a little bit of graft versus, you guys can sit down now. A little bit of graft versus host disease is not a terrible thing because it probably means that graft recognizes the myelofibrosis cells that may be left behind as something you don't want there. So it's kind of a double-edged sword. But
so do you have now, before the procedure, indicators of who that last group might be based on history, or there's just no way of knowing?
There's no way of knowing. I mean, we think that maybe there's probably a less chance with a matched related donor from matched unrelated donor, but you usually can't really pick your donor. We know in the setting of using a mismatched unrelated donor that the number who get graft versus host disease would also probably include the front 2 rows here, and maybe the severe ones would be a little bit more. But aside from that, when you're looking at a matched related or matched unrelated donor, there's very little above and beyond that can really help us predict graft versus host disease. And it's not for lack of trying. I mean, people have sequenced the heck out of genes and looked for genes that are associated with it, and different polymorphisms, which are slight variations in genes that aren't even abnormalities, but just differences that we have. We have not been able to figure out a way to predict who that front two row, who will be in that front two rows. The other complication is infection. So, everyone gets worried about infection after transplant, and it makes you remember to wash your hands, to clean everything well. I always tell people, if you've been able to raise a child, you can probably take care of a transplant patient, because it's the same basic thing you think of with a baby. Now, the biggest thing is right after transplant, it's actually stuff inside your body that's the biggest problem. We all are teeming with bacteria. We actually have 3 times as many bacterial cells as we do regular cells in our body. So we are all covered with bacteria. When you're neutropenic, or when your white blood cell count's really low after a transplant, that's what actually gives you the worst infections. After that, your immune system is suppressed for a while. So even once your counts recover, so patient comes in, they get their neutropenic, their counts recover, and then we're like, woohoo, your counts look great, you can leave the hospital. It doesn't matter. Those counts still don't work well. It's like you have guns but no ammunition. So you still have to be very careful. As a result, we put a lot of restrictions in place for transplant patients. We don't want you to go out in crowded places. We don't want you to go out to eat and eat salads or fresh fruit, because we all know how salads are kept in big bins in the back of even a nice restaurant. We don't want you to go out and dig in your garden. So people who enjoy gardening, I say, okay, no, you can't dig in there for at least a month. I had a patient who said, well, I'm going to go ahead and go out and use my backhoe instead. And the guy had disseminated fungal infection about 6 months later. So you have to be very careful. Now, that being said, you can, you can be smart about it. And most of the patients, this year is particularly difficult because it's such a bad flu season, but a lot of patients don't get viruses after their transplant because they're so careful about it. But you do have to be so careful, or else you will get sick. The patients who do get sick are generally ones either who have kids or who say, well, I'm going to go to church anyway on Christmas Eve with all the kids around me coughing and crying, and then they come in with a virus the next week, and you say, well, I'm sorry, you really shouldn't have gone to church, as much as I appreciate you wanting to do that. So what happens? So again, this is kind of outlining what we've just talked about. You have the donor, and you have the patient. So donor, patient. You want the positive impact of the immune system as the graft versus infection, graft versus tumor. You don't want the graft versus host disease. Unfortunately, we cannot separate them. Out of all of our advances in transplant have primarily been in controlling infections. We still have a lot to learn about graft versus host disease. So what is required from a transplant patient? You have to live within 30 to 60 minutes from the transplant center up until day 100. You need to plan on taking about a year off of work. You need a 24/7 caregiver. Just family doesn't need to be medically trained, but you need a caregiver the first 100 days. The living within the time, close to the transplant center and the 24/7 caregiver are generally not negotiable points. The year off of work, sometimes we tell people to plan on a year, but sometimes people can go back earlier depending on what they do. And then we put a lot of restrictions on you, as I mentioned above, to prevent infections. So why would you want to do this to yourself? Well, right now, this is the only cure we have for myelofibrosis, unfortunately. So if you want a curative option, this is it. It doesn't mean you have to have a curative option, because there's lots of things you can still do to treat the disease, but they don't fix it, as has been mentioned by a lot of the previous speakers. So when to do this? I don't have a great answer for this, to be completely honest. And I don't think anyone does. And we're really trying to look at this carefully to try to understand when is the best timing for people. It's generally reserved for higher risk patients. It's very important to know your risk. You've heard from multiple speakers this morning that this disease is incredibly complex genetically, et cetera. It's very important to know what your risk is, because we have ways of detecting risk, but you need to kind of understand where you are on that spectrum. So how do we define risk? There's first the DIPS. You heard this in the previous talk. And there's a DIPS plus, and these all basically take a bunch of clinical factors and come up with a score that tells us whether you're a low risk, intermediate 1 risk, intermediate 2 risk, or high risk. And that's associated with certain survival. So I come up with this kind of graph as a way to look at this. So when do you do transplant? So you see there's a diagnosis of the disease. At this point in the time, this is sort of the spectrum of disease over time. At this point, you're too early. You probably don't want to do transplant because you have too much life left in front of you, and transplant can cause people to die. So we don't want to make that happen early if we don't need to. If we wait till you're really sick, till you're really feeling the disease and you're high risk, you have organ dysfunction, at that point we've missed it. At that point, you're sick, you're not going to have a good transplant outcome, and a lot of times I don't recommend doing transplant at that point because I feel like I'm putting you through a lot for something that may not provide you a benefit. So when it's just right, we think it's probably somewhere in the DIPSS intermediate 2 risk. Now, the thing is this risk you can be in that risk category for a number of years. So we don't, where in that time frame do you choose to do the transplant? I mean, this could be a sum total of 15 years if you look at all of this. This could be 5 years by itself. I mean, that's a huge frame. So you say, okay, I've hit this risk. When do I do transplant? That's where the risk comes into it. Looking at other factors, knowing the cytogenetics. So these are chromosomes in your bone marrow that are abnormal. This is not something you've inherited. This is not something passed on to your children. This is something that we know by looking at it. And there's certain chromosomes that are a little bit more considered higher risk than others. There's also the molecular mutations, as people have alluded to. There's all sorts of other mutations we can look at. And some of them have been associated with a worse prognosis. So if you have higher risk molecular mutations, those are also reasons to potentially say, well, maybe we need to think about doing transplant sooner rather than later. The good news is that there's emerging data coming out that even if you have bad risk disease based on molecular mutation cytogenetics, this does seem to be something you can overcome with a transplant, which is actually very unique to myelofibrosis, because when I look at patients with acute leukemia who I bring into transplant, I know somebody who has bad risk going in has a higher risk of relapse afterwards. But in myelofibrosis, we actually seem to be able to overcome some of these risks that precede transplant. So looking at all these risks and thinking about these risks, we try to say, okay, well, you have too early, you have just right, you have too late. So if you have bad risk mutations, I'll say, hey, you know what? The minute you kind of cross over into the intermediate 2 range, we probably should bring you to transplant. If you don't have bad risk mutations, you have kind of standard risk disease, I think we have more wiggle room and we can probably wait. Again, I don't want to wait till you feel terrible and you're symptomatic. If you have a big spleen, if you have organ dysfunction because you're making blood in other parts of your body, that's probably when it's, that's where the risk of transplant becomes a lot higher. And although it doesn't preclude you from getting a transplant, we really want to be careful of when we do this, because I don't want to wait till somebody is really ill, because then you just aren't going to get that much of a benefit. Now, in some patients who have a particularly high risk profile, where we know that people tend to progress faster or have the risk of conversion to acute leukemia, I sometimes even consider transplant with intermediate 1 risk. And that is, again, primarily based on looking at the biology of the disease, the mutation analysis, et cetera. Other things to consider, as I said, symptom burden. I don't want to wait till you're really sick and have a poor performance status. Other thing is, what do we do with Jakafi? This is an ongoing question that we don't have a perfect answer to. Generally speaking, what I like to do is I like to say, well, if you're on Jakafi and you have a nice response, I don't want to wait till you lose that response too much, because then I know that the potential of having regimen-related toxicity may be higher. I can't say that for sure, but it just makes logical sense that if you're feeling better, your spleen is smaller, you'll probably have a better outcome with transplant than if I wait till you've progressed with Jakafi, your spleen is big and you feel terrible and you're cachectic. Then you come into transplant in a worse situation and the outcome will probably not be as good. But it's a very hard balance to reach, because you say, well, geez, I'm really getting a good quality of life from Jakafi. I might have this for years. So where in that time frame do we do a transplant? And again, that's part of the shared decision making. That's part of the discussion you have with your physician, your transplant, your non-transplant physician. It's important to keep these in mind. Transfusion dependence. Usually if somebody starts requiring red cell transfusions, I like to bring them to transplant, just because of the fact that when you get more and more transfusions, you end up building up immunity, so you might have a higher chance of rejecting the bone marrow that you get in. And also you build up iron, which we can ultimately take care of, but it can add some challenges. And then finally, life events. I mean, some people, they'll say, I really want my daughter or son to graduate high school before I do this transplant. And I say, that makes perfect sense. Or I have a wedding I really want to go to in October. I really don't want to do transplant until then. Or I have this trip I've been planning for so long. That is fine. Our backs aren't up against a wall with this. There's never a situation where you need to go to transplant right now. With acute leukemia, that's the case. I can't give people these luxuries of saying, oh, I want to wait until, you have somebody graduates or somebody gets married. But in myelofibrosis, we have that potential, which is good. So what happens to the marrow after transplant? We actually, you can improve the cellularity. So we look at how many cells are in there, how full is your marrow. That can actually become normal. You can actually, after 1 to 2 years, get rid of all the scar tissue that is in the marrow. It's pretty cool when you do a marrow and they don't actually comment on any scar tissue. So it's a very nice thing to see. How will you be monitored? Again, you're monitored very closely up to day 100, and then after a year, once as things go on, a lot of it really depends on complications, infection stuff that you get, but you are monitored. After day 100, you usually go back to your referring physician, but still need to keep in close contact with your transplant center. So in summary, bone marrow transplant is a curative option for myelofibrosis. The timing of transplant requires a lot of discussion, requires a shared decision-making process between you and your physician. It's not a straightforward thing. I can't say at this point, absolutely, you got to get a transplant. There's so many factors that go into this. Know your risk. I can't stress enough to know your risk, because that is really going to help you determine timing for transplant. And then recovery after transplant may take a while, but it is worth it in the end. And just to end on a happy note, I have a couple of pictures of my survivors. They gave me permission to put these pictures up. She is a little over 2 years out. This is her and her granddaughter. They were able to go up to the North Pole experience in Flagstaff, Arizona. And then she's about a year out, and this is her. And she moved back to Hawaii and with her son, who got an award at school. So it's just to show that there is life after transplant. There's a lot of bad things that can happen, but people can also be survivors and do quite well. So.
Two quick questions.
Uh-huh.
I heard that you can assume that you'll never be better than 80% of what you are today after a transplant. Do you find that?
Well, it's kind of, it depends on what you're trying to put as your baseline. First of all, there's a new normal. The new, and this is actually a really interesting question, but the new normal is kind of where you are after you survive a transplant. It's a very hard thing to characterize, because, every step along the way will define what normal should be or could be or may not be. I think the tricky part is that if you have somebody who's feeling well and they say, okay, well, based on my risk, I'll have 5 more years. It's assuming you're going to stay well for that 5 years. Whereas if you go through a transplant, the assumption is, oh, well, if I start here, I'm going to end up here. And that's not the case. People can go into transplant, like, for example, this patient right here, I remember she got into the hospital, and within a week after getting all the chemo and knocking out all the cells, she actually felt better. And she went on to transplant, and actually I think now has a better quality of life than she did right before she came in. Now, is it like before she ever got sick? I don't know the answer to that. I don't think anyone does, because your whole frame of reference shifts after a transplant. Some people actually feel after a transplant that they have a greater appreciation of their quality of life and actually feel better after a transplant from a very spiritual, emotional, because it's not just physical, it's also how you mentally feel. And so a lot of people actually feel better because they've overcome that obstacle. So it really varies. So it's not a black and white answer.
And the other quick thing is, how long have you found it takes one to be careful of their immune system before you can resume their normal life? Is it a year?
That's a gradual process, and it depends on a lot of things. Like, there's chronic graft versus host disease, which means you can be on continued immunosuppression. We're really not very good at measuring immunity. We do have to provide vaccines for patients, but that provides some protection. But even though a lot of people don't vaccinate, we still have some degree of herd immunity present, so that you will be protected from things. So the long and short of it is nobody knows the answer to that. I think after transplant, people just get so germophobic that they wash their hands continuously anyway. But you can eventually get back into just regular life. I don't know what the exact time frame is, and it's different for everybody.
Thank you, Stuart, for